All right. So thanks everyone for tuning in to this edition of the National Fellow Online Lecture Series. I'm Robbie Bowers at Emory Sports Medicine in Atlanta, and I'll serve as the moderator for tonight's talk. So this is our first lecture after the annual meeting from last week. And so I just wanted to put out a congrats to everyone who was on the program planning committee. It was an outstanding meeting, and it was really great to get back in person and see everyone in person. I think it was one of those things where I at least didn't realize just how enjoyable it was to see everyone in person and not have to do everything over Zoom. So it was a great meeting last week. So thanks again to everyone that worked hard to put the meeting on. Then also, we're going to transition to new co-chairs here soon on this, the Fellows Online Education Subcommittee. So the outgoing co-chairs, Nate and I and Heather Staff, will just want to say thanks for them for the last academic year and coordinating all of this and putting it together and just providing a really great resource for not only fellows, but all of the AMSSM members. So before we get started tonight, wanted to plug the next lecture in the series. That's going to be next Wednesday, 8:30 p.m. Eastern Standard Time. It'll be on supplements and performance enhancing substance. Melissa Gibbons will be the speaker and Julie Creech will serve as the moderator. So tonight's talk will be on testicular and scrotal injuries with Dr. Brad Sandella. And before we get started with his talk, let's just go through a couple housekeeping issues. So again, these sessions are not supposed to take the place of anything provided by your program, just to provide you access to different AMSSM members in a variety of formats, and really to help you prepare for your CAQ exam. Again, if we don't do it for you, mute your device's microphone, turn off your video, submit your questions through the chat function. And then at the end of the talk, I'll go through and ask all of the questions to Dr. Sandella, and we'll have a discussion afterwards. So just go ahead and put your questions in the chat function, and I'll ask them. And then after the program, please complete the evaluation, which we will send and put in a link to it in the chat function as well. So again, tonight's edition of the National Fellow Online Lecture Series is on testicular and scrotal injuries. Dr. Bradley Sandella will be the speaker. Dr. Sandella completed his medical training at Philadelphia College of Osteopathic Medicine, graduated in 2006. He did his residency at Christiana Care Health Services, and then his fellowship at St. Joseph's Regional Medical Center. He's now back working at Christiana Care from what I can tell, Delaware and Pennsylvania, I guess close enough to Delaware, but also in Pennsylvania. But this is definitely, as I posted today, I think an under-discussed and very, very important topic. As an example, one of our professional football players here in Atlanta had an in-game testicular torsion a couple of years ago. I wasn't there, but it's just one of those things where you have to know how to manage these things in these emergent situations. And so we thank Dr. Sandella for being here tonight to provide this very important talk. So Dr. Sandella, please take it away. Thanks.
Dr. Bowers, thank you very much. And thank you for having me. And thank you to everyone in the audience. It's such a pleasure to be here. I'm going to bring up my talk so that way you guys can see my screen. We good to go? Awesome, thank you. And let me just make this at least presentation mode. So, testicular and scrotal injuries, it's interesting, as just kind of mentioned, it's not something that we think about all that often. But over the course of the talk, I thought I would take an opportunity to share at least two sideline stories from events and how it relates and how this can be, even though under-discussed, maybe underutilized, kind of critically important, and the type of knowledge that it's helpful to have, kind of in your back pocket so you can use it. So please feel free. I mean, I'm open to all questions. And then also, if anything pops up afterwards, question-wise, feel free to, send me messages. I'd be happy to talk to you anything about this. So before I go on, I just want to mention that I don't have any disclosures. There's no financial relations. So throughout the course of the talk, we're going to cover a couple, specific things. We're going to talk about the anatomy of the testicle and the scrotum. We're going to talk about some, regular conditions that you will face, management and evaluation, which I think is always critically important, especially for a fellow. When you start to talk about, return to game and return to play decisions, some solitary testicle conditions. And then I was going to kind of wrap up with some of the best evidence that's out there. So that way, when you're trying to make decisions, at least you are the most prepared. So when we start to talk about the anatomy, this is going to be a callback to your days in anatomy class. So some of these things might sound familiar, might have to knock the rust off. But typically, when the testicle develops, it usually begins around 4 weeks of embryonic development. And at that point, as the testicle begins to develop, about 3 months, into pregnancy, this testicle that's begun developing early on slowly begins its descent. And typically, at that point, it starts to pass through the abdomen. And, this is influenced by two hormones, more or less, the insulin-like peptide hormone and testosterone. And as the testicle, as they descend through the abdomen, they pass through the abdomen into the scrotum through the process vaginalis. And then once they pass through the process vaginalis, that closes. And then what happens is the anterior 2/3 of the testicle becomes surrounded with the tunica vaginalis. So once again, these are terms that you probably heard way back in the day. And this essentially is what creates the shell and your testicle. So the structure, as I just kind of mentioned, is this, cylindrical shape that's covered by this process, this tunica vaginalis. The epididymis is actually situated in the posterior part of the testicle. We're going to talk about epididymis and epididymitis shortly, and about how that's really close to a lot of these significant conditions and how you need to be able to thoroughly be able to tell the difference between the two. But we'll get to that shortly. And then most important, it's also worth mentioning, the spermatic cord. Now, the spermatic cord is actually made up of the testicular artery, and that's what's going to supply the majority of blood to the testicle. And then when the arteries, when they drain, they drain into the pimpiform plexus, and that's the veins. They all collect. Those two structures, along with lymphatics and the vas deferens, form the spermatic cord. So that's actually what forms the cord. And, keep all that in mind when we talk about torsion injuries and things like that. And then just for anatomy's sake, and just for, when you're evaluating, it's also important to know that typically when you're evaluating an individual and their testicles, usually the left testy actually sits a little bit lower, suspended a little bit lower in the scrotum. So if you realize that, that could also help you when you're trying to evaluate for an injury. So what are the conditions that we have to face? Well, I'm going to give you a differential in a minute, but typically testicular conditions can come from blunt force trauma, but the majority of them, that's not necessarily the case, or at least it's not necessarily happening during athletic competition. It can happen at any time, but you can have blunt force trauma to the scrotum, to the penis itself. But of those structures, 90% of them are typically testicular in nature, and usually it's unilateral. Very infrequently will you see a bilateral testicular injury. 5% of the time there might be an associated penile injury, but the majority of times we're talking about testicle. And usually it's because of its location. It's essentially your scrotum is hanging off of the body, and it's just in a very vulnerable spot for it to get injured. The other, just for epidemiology purposes, the peak age of trauma is typically 10 to 30 years of age is typically when, so this is right in the wheelhouse for, lots of athletic types of injuries. These injuries can affect, of course, both athletes and non-athletes. So, as you can imagine, it's athletes that we think about with sports could also be just recreational activities that can lead to this types of trauma. And severity, it can range. But the one thing that's important to remember is when we talk about some of these conditions, they can be a medical emergency. And I will tell you, and you will see what I feel is the most important slide in this talk, and I will call that out for you, because that could mean, you know, the difference between a very good outcome and a very bad outcome, depending on how you manage a condition. Typically, the presentation is key. And I think the second most important slide in this talk is a chart. It's about halfway through that puts two conditions pretty much side by side. It puts testicular torsion and epididymitis side by side, and you can compare and contrast those two. And I think from those two, you will get a lot of information that will help you sort out what you're dealing with and how you need to act. And then I already kind of mentioned, you know, what your management is, and I'm going to go through detail about what you need to do. So this is that differential I told you about. You know, I think, you know, at first blush, the first thing that pops to mind, you think about contusions and torsions, but there's a lot of other things that can happen. You know, you could get ruptures. You can get you know, swellings and things like that. But the other thing that, you know, it's funny, I've given lots of talks on this topic. I've published an article, but one thing I had never mentioned until this morning or this afternoon when the announcement came out, and I got to give credit where credit's due. My former program director sent me a text with, you got to be careful about frostbite and actually cold related injuries as well. So thank you, Steve Simons. So jumping into this, so, you know, one of the first things you think about is a contusion, testicular contusion. And this should always be very high in your differential. Any type of direct trauma to the area can cause a contusion. Typically, you can handle them without too much, you know, emergent need. Often, you know, non-operative, you know, aggressive non-operative management, meaning ice and elevation. Elevation, you're using a sling to support your testicles is pretty much what you need. But, you know, if somebody takes a blow, direct trauma from a blow can lead to potentially a torsion. So you have to have that on your consideration. So if there is no improvement after icing and resting somebody, you need to have that on your differential, and you need to go down your algorithm for how you would take care of that. If the mass expands quickly, you got to think about fractured testicles. And this leads to the first story I'll tell you. So to kind of bring this home, a couple of years back, I was covering a lacrosse game, and an athlete, lacrosse player, was wearing a protective cup even, but when he shifted, when he rotated, his cup rotated with him, and that allowed the space between his leg and the cup to gap just wide enough. And it so happened that he took a lacrosse ball to that area. And it was very concerning because it was direct trauma, and we all know how hard a lacrosse ball is. By the time I got to an evaluation, which was within a few minutes, you know, his scrotum and his testicle was severely swollen, and it needed, you know, that was that situation where, you know, it was between contusion and fracture. I wasn't necessarily thinking torsion, but it was significant enough, and it was swelling so quickly. Not only was I losing landmarks, but the concern was very high. So, you know, this is what you have to be thinking about at all times. You know, the other thing you got to think about is when you are doing your exam, you know, you feel around all surfaces of the testicle. And if you can't feel the epididymis and you can't feel it separate from the testicle, you know, you might want to think about epididymitis. So at least when you have this, so these all have to be kind of working all at the same time. So if you're concerned that your contusion is more than a contusion, and you're thinking about a possible rupture, you know, you got to think about, you know, with a testicular rupture, you get a rupture of the tunica albuginea. And what happens is you get this extravagation of the fluids, and the tubules comes out. And what that can lead to is that can lead to a hematocele. So you get this, you know, direct blow from compression of the scrotum, often against your pelvis or your thigh. And what it does is it causes enough of a compression where it can it can rupture and squeeze, and then things will come out. The problem with a hematocele is that if it's small, like less than 5 centimeters, they can usually spontaneously resolve, and you're usually okay. But if they're too large, they can actually become problematic, and sometimes they require surgical evacuation. Now, there's no way you would know that from at least a sideline eval, so you might need some diagnostic imaging to help you. And one of the things that can help you is an ultrasound. So if you get an ultrasound, and you can measure, the testicular size, you can measure for a hematocele, but you can also check to see if there's Doppler flow, if there's blood flow. If there's blood flow to the area, that's a reassuring sign. That tells you that you're getting good blood flow there. If you happen to not see blood flow, you need to be very concerned, and that could require surgical management as well, because if you don't have blood flow, that's going to cause an ischemic testicle. And that's the other story I can tell you is we had another player who, different situation, same sport, who took a ball to the testicle, and he was evaluated emergently, and he was ruled as a contusion, and he had management and he did fine. Well, the problem was he never really followed up, and when we were seeing him for an exit physical, I was going through and I asked him about this, and he kind of told me that he never really followed up, and he was still having some problems. So I asked to take a look, and when he showed me, his scrotum was still incredibly enlarged and it was rock hard. And we sent him for an immediate ultrasound, and there was diminished to almost no blood flow to the testicle. We were scared to death that he was going to lose a testicle. Thank God he didn't. But those are the things you have to worry about. So, more importantly, and I think one of the topics that pops up quickly in our minds whenever we think about, testicular injuries is torsion. And this is one of the most significant conditions, and something you need to be high on your radar. What happens with a torsion is you get a twisting of the spermatic cord, and as the spermatic cord twists around, it can actually cause an ischemia, and that ischemia can be tissue threatening. So the most common age group is adolescent males. It's kind of redundant, I guess, male part for this, but we'll leave it as it is. 65% of the cases are, in the age of 12 to 18. So these are going to be some of your younger athletes. So maybe your high school freshmen, sophomores, but it can happen beyond that. But that's just the most common time you'll see this. And the incidence is about 1 in 4,000. So it's not terribly uncommon. This could be something that you definitely deal with. And you heard, Dr. Bowers mentioned a football player. So this is there. Only 4 to 8% of these result from trauma. So this can be, a runner or an athlete that was doing something without trauma when this happened. So we're going to talk more about this picture in a minute. But just kind of keep this in the back of your mind, and I'll come back to something like this, but I wanted to just include this so you start to think about, this is the most important slide. Look, I'll even flash that for you. But if you have a suspicion of testicular torsion, this needs urgent, emergent evaluation, as this is a urological emergency. And I'm going to show you the statistics on how significant this is when, in a few slides. But if you do not get this taken care of, within the first 6 hours, the survival rate of the testicle starts to drop. And that's something you need to be very concerned about. So there's 2 types of torsions. Now, I do this for completeness sake, I'm going to tell you, but you will most likely never see an extravaginal testicular torsion because this happens in neonates. So unless you're moonlighting in the NICU or a labor and delivery floor, you probably will never see this. But this is typically due to an undescended testicle, and it involves torsion of the testes and the spermatic cord. But that's enough about that. Let's talk about what you could see. Is this intravaginal? And this is the one that typically affects those males that I kind of referenced earlier. And it represents about 90% of the cases. So you can see this is the majority of the cases is this intravaginal. And most often it's a congenital malformation. So if you think back to the picture I just showed you, and you look at the picture in the top corner of this is what happens is you get this bell clapper deformity. Now, if you don't know what a bell clapper is, I didn't know what a bell clapper was either until I read about it. But a bell clapper is the little thing that hangs down inside the bell that makes the ringing noise when it bangs against the sides of it. So typically, normal development, what happens is the posterior aspect of that tunica vaginalis we talked about, it's adhered down and it's stuck down to essentially the side wall or the back wall of the interlining. So the testicles kind of adhere down, and it doesn't freely float. In a bell clapper deformity, the gubernaculum and the epididymitis and the testis, it's not as adhered down, so it's by far more mobile. And what happens is it can swing and oscillate more aggressively. And if it's not adhered down, it can involute and actually twist upon itself, and that's what leads to the torsion. So that's kind of where the picture is. So what does this look like? That's kind of what it's described as. So what does it look like? These individuals, they're in severe pain, acute onset of pain. It can be unilateral to the side that's affected. It can be so encompassing that it just feels diffuse and it feels like it's everywhere. Tenderness, you can barely touch. It hurts. This hurts. Often, your athlete's gonna be lying on the floor in pain. They might make it to the bathroom because of the sensitive nature in the area of what we're talking about, but they'll probably be lying on the bathroom floor in pain. Often they're nauseous. It's almost like you're getting kicked in the area. You might even vomit. But once again, remember, there's only a small percent of these that are traumatic. But if you have somebody that has just intense pain, nausea, vomiting, this has got to be on your radar. Fever, reported in 25% of these people, probably because of the inflammatory process that's going on. And you'll see even there's certain markers where this is elevated, but they might even have fever, but there's no urinary complaints. If they can urinate, they're not having dysuria, frequency, or urgency. They're having pain. The one physical finding, well, we're gonna I'll flip. A couple of things you might look for is, first of all, you might see the testicle having a horizontal lie. It doesn't lie as vertical as it typically does. You might have a little bit of a horizontal lie to the testicle. You might have lots of swelling and edema. So that could also complicate your exam. So this is one you want to see quick. You want to get on it and you want to see it quick. You could see this blue dot sign, and that's the translumination. What I'm gathering is the blood's passing through those venous structures, and because of the venous congestion, you get this blue discoloration on translumination. I'm going to talk a lot about translumination in this talk. I don't know how often we transluminate things, but this is an area, maybe this and your sinuses are probably the only things you might ever need to transluminate, but this is one thing where it can be helpful. So if you transluminate, you might see this bluish hue discoloration. If you've never heard of Friend's sign, Friend's sign is where you elevate the testicles. So you can either use your hand or a sling or something or underwear, and you physically lift the testicles. Typically with several conditions, and you'll see this with epididymitis, where they actually get relief when you elevate because you're not hanging on the spermatic cord. Well, this is not a tension issue. This is a torsion issue. So even if you elevate the testicles, they don't get relief. So the Friend sign is this situation, there's no decrease in pain. But probably the most important thing is the cremasteric reflex. So cremasteric reflex, you stroke the inner thigh. So you kind of, as you bring your hand up their thigh, on their medial thigh, what you look for is the side that you're touching, you're looking for an elevation of the testicles on that side. In torsion, you do not have that reflex. That reflex is absent. So that is actually 99% sensitive in this condition. So, of course, it requires privacy to do these types of things. The whole exam will be done in private, but this is one that you do this and you're looking for that elevation. If you don't see that, it's time to act. So what do? Well, this is one you want to send them in. So you send them in right away. This needs immediate evaluation. And immediate evaluation is, what does that mean? Well, you could do some labs, you could do some diagnostic tests. Typically labs aren't all that helpful. Usually your analysis is normal. You're not really going to wait on labs to come back. So getting CBCs and stuff like that aren't going to be super helpful for you. You could do a Doppler, or you could do a scantography, which we'll talk about in a minute, the sensitivity. But this is a time sensitive condition. So it's probably not going to be worth it to wait for those tests. If the suspicion is high, surgical exploration is the gold standard. So typically, the person presents, they have a testicle that's firm and swollen, tender. Story matches up, physical symptoms. Maybe you did a limited exam. This is one where the surgeon's coming in and they're going to take this person to the OR because they need to detorse. So if you don't have a surgeon, or there's a delay, or if you're a little bit unsure, you have about 6 hours, so you could get some tests to help you. I just told you that, ultrasound and the scantography are your two best tests. High frequency Doppler studies with ultrasound, pretty good sensitivity and specificity, even better with the scantography. You can see up to 98 to 100%. So it will tell you for sure what you're dealing with. But remember, time is of the essence here. What do you do if you can't do surgery, or you can't get a surgical evaluation, or say you're in a remote location and you don't have time? You can manually attempt to detorse. So a manual detorsion, what you think about is, and you may have heard this before, but essentially to attempt a testicular, detorsion, it's like opening up a book. And what I mean by that is typically the testes, they torse, or they rotate towards the midline. So one thing you can always remember is, if you're not sure, do I go to the left? Do you go to the right? Imagine you're trying to open up a book. So the book's in the person's lap. So you would open it to the out. That's how you detorse somebody, is you try to manually unrotate them towards the lateral, going outward, going away from the body is how you would manually do this. But the success rate is, very concerning. 26 to 80% success rate are not odds that I would probably be caring for to want to go with. So maybe you take a shot, especially if you're, in the field, but it still requires evaluation. So this is where I was telling you about the importance of time. If you can evaluate, treat, and get this person, cared for within the first 6 hours, 90% success rate that you will salvage that testicle, and you will save that testicle. As you see, it drops off precipitously from that point forward. If treatment occurs within the first 12 hours, it's down to 50-50. So 50, waiting, 7, 8, 9 hours, 50% chance that that testicle will be unsalvageable. After 24 hours, 10% success rate. And anytime after a day, you're at 0%. So if this takes up to a day, now I can't imagine in what type of situation that would occur. You would have to be in a real remote situation. But you see that it's pretty much at that point, the ischemia will have caused death of the testicle. So unfortunately, it will not be salvageable. If you have the best case scenario, which I'm sure we would in this situation, you identified it early, you've gotten them cared for, they got surgery. Now, keep in mind, by the way, typically when a surgeon will go in, they will fix and they will do a, orchoplexy, where they will tack down that testicle and they will actually reduce that bell clapper deformity. They will also explore the contralateral side as well, because typically there can be a bilateral nature to this, and maybe just one got torsed. But because they're already in there, they will look, and if necessary, they will do a procedure on the opposite side as well. Typically, though, the return to play is not all that bad. Once their surgical wounds heal and their pain has resolved, they're good to go. I mean, typically, they'll get, the surgeon will have the final say, but typically once the surgical wounds are healed, they're good to go. So the downtime, it's not like this is a season-ending injury if it happens early. So whatever typical wounds take to heal will be your downtime, and then they can get back to playing. There's question if a protective cup is necessary, and I'm going to tell you about the evidence of protective cups at the end of this talk. So keep that in the back of your mind. Cups will help with, excuse me, protective cups will help with blunt force trauma, like contusions and fractures. It could help reduce torsions from blunt force trauma, but if there's the ability for them to torse, that still could happen. So keep that in mind. Now I'm going to contrast that with another very common condition in a very similar age range demographic that you need to think about. So epididymitis is inflammation of the epididymis. Sorry about the typo there. I should say epididymis. Most commonly, it's from a pathogen that is sexually transmitted. So you got to think about gonorrhea most typically. This is not uncommon. I mean, 6,000 cases a year in the United States. So this is actually quite common. The population, it overlaps, but it goes a little bit older. This is 18 to 50. So you can see that those higher age range for torsion, lower age range for epididymitis, but right in that sweet spot of college is pretty much where you could see either one of these two things. There's 3 different classifications. So when you think about the symptomatology, that doesn't mean it defines the problem. That just defines often when there's pain, but it can go a lot longer. So the 3 subclasses are, there's acute, and that's the most common. And this is typically what you see in that first 6-week frame. Typically the cause is a retrograde bacterial infection. And once again, we talked about some of the pathogens, but this is what you will see. I'm going to jump to the chronic. The chronic, these are people who have had symptoms typically for 3 months. At this point, they might have some low-grade pain, but it's not awful. Typically, there's no more swelling, and it's subacute. It's not an actual. The subacute is the ones in between there, but this is even less painful than the subacute phase. So typically, if it's less than 6 weeks, it's acute. If it's greater than 3 months, it's chronic, and anywhere in between is subacute. So we started talking about some of the symptoms, but let's just review them. So pain, often pain in the back of the testicles, because that's where the epididymis is. It can radiate up into the abdomen because of the tract of the spermatic cord. You might have urinary symptoms. You got to think about potentially, UTIs and stuff along those lines. Maybe there would be some warmth or redness. But interesting enough, one of the differentiating things with this and torsion is friend sign. So if you elevate their testicles, they will have improvement in their pain. And once again, that's because of the traction on the spermatic cord. Excuse me. So what do? Well, you do an examination. And this is one where, once again, you examine the testicles, but you examine the posterior side of the testicles. If they have tenderness along the spermatic cord and the epididymis, you got to have your radar up there. You can get some testing. This is one where, SED rates and CRPs can be helpful. Urine analysis you can also get because you might see some positivity there. Typically, you'll see white blood cells, maybe some leukoesterase, but also if you were to get a color Doppler, typically you see huge increases in blood flow. Once again, because of the inflammatory nature of this whole thing, you might see a huge influx of blood flow to the area. With torsion, you're happy you're seeing blood. With epididymitis, you might be happy you're seeing blood, but that could also be a clue that there's something going on. How do you treat this? Well, we're going to give them antibiotics. Now, you guys know as well as I do, with athletes, you want to be careful about your choice. Your ceftriaxone is the drug of choice for this. You can use Doxy if there's an allergy. Cipro is often listed, but with athletes, you want to be careful with fluoroquinolones because of tendon concerns. But you want to get them on the right antibiotic. Typically if you have something that is sensitive, that's what your ideal is. Pain control, typically these people do not need hospitalization or surgeries. Of course, if you find a pyelo, you want to be on the lookout for that too. But typically these people do perfectly fine with just the right antibiotics, and then they're back to activity. This is the second most important slide I was talking about earlier. So this gives you a good head-to-head comparison. You can see the crossover. We talked about the age, talked about pain, both have swelling, but then you start to get to some of the differences here. Urinary symptoms not so present with torsion, but definitely with epididymitis. Friend sign, cremasteric reflex. So with epididymitis, cremasteric reflex is maintained, not so much with torsion. We talked about, perfusion studies and treatment purposes, but this is something you may want to look back on, especially when you get ready to take your boards. This might be a helpful chart for you. Moving on, something I think it's worth mentioning, especially in this age range that we're talking about, are tumors. So, this is in that age range of 20 to 35, this is the most common solid malignancy that you might see. So, we all know about to look for this and to check for it, but it's true. So, incidence is increased probably because we're more cognizant and we're looking for it more. Roughly 1 in 300 males. Numbers are actually more significant than they are with torsion, which was 1 in 400. So super high, super high survival rate. So people do well because typically we catch these things early and people do great. An undescended testicle or a prior tumor are huge risk factors. So if you see that or you have a history of that, that's something you want to know about. That's why we ask about those questions on the PPEs. Germ cell are the most common, with seminoma being the most common of all of them. Non-germ cell tumors, they only make up about 10%. So most of them are going to be germ cell, 90% of the tumors. And you see these, after puberty, but you'd be on the lookout. These present with pain is often not present. So, what you're going with is your physical exam on this. So, we're going to talk about recommendations about, do we do testicular exams on PPEs? And I'll give you at least what the evidence shows. But you might have somebody who picked it up maybe themselves. And, if they did a self-testicular exam and they picked it up, you do your exam. Often the way this is described is it's like a pea that's been cut in half and stuck onto the back of the testicles, how this is often described. So you're feeling for a very small, firm, non-tender lesion at the posterior aspect of the affected testicle, and that's what you're going with. If you see that, get out your pen light again. You're going to transluminate. You transluminate, no light should pass through it. It's solid. Tumors are solid, as you know, so you should not get a translumination. So you transluminate a torsion, you see blue. You transluminate a tumor, you see nothing. You could also look for indirect signs like, gynecomastia, because of the hormone secreting nature of some of the germ cell tumors. So keep that in the back of your mind as well. If you get imaging, you could get, an ultrasound. We do a lot of ultrasounding. So this is another time where you can ultrasound. You can look for a hyperechoic signal. Once again, these are solid. So you're not going to see, evidence, reflection passing through. You most likely, though, this is one where you're going to MR like you do with all other tumors, and you're going to look for, some type of enhancing, study with, T1, T2 imaging. Getting some laboratory tumor markers could be helpful for you, especially for looking for progression. You're not going to use it to make a diagnosis, but monitoring progression can be very, very helpful for you. So these are all the things you can get to that you can help, at least with the process and as you go through it. Treatment of choice is surgery, as you can imagine. So they go in radical or orchiectomy. They will also check for undescended testicles on the opposite side. Typically, radiation and chemo might need to be included as well, following those markers that I just told you about earlier. And then we already talked about preventative. Return to play with this is similar to torsion with surgery. Once surgical wounds heal, pain resolved, this is another one where it's questionable as far as cup. But one thing that's not questionable is counseling. This is a condition where you want to talk, this is a solid organ. So you want to counsel an athlete about return to play with a singular paired organ. Can they return? Yes, but they need to be counseled. They need to know their risks. And it's crazy, but one of the things you could counsel them on is sperm banking. Odds are low, but they could potentially get hit. That's why cup is recommended in this situation to prevent from that blunt trauma, because the last thing you want to do is put a solo paired organ at risk. A couple of things that's worth mentioning. A couple of things we talk about: scrotum, varicocele. It's pretty common. 20% of males will have this. This is that, you remember from med school, the bag of worms. Can be painful. Decreasing testicular size and infertility if really large, that would need to be addressed, but typically this can just be monitored and managed. You don't have to do too much there. Spermatoceles, once again, you get extravagation of the sperm due to either trauma or infection. That can actually cause a collection. Typically, once again, non-aggressive, or aggressive non-surgical management, but if it becomes large and painful, you might need to treat it. Hydrocele, I thought I better include a picture of translumination since I talk about it a lot, but you can transluminate for this. And this is one that it will transluminate, through because it's just fluid. So as compared to the hematocele, which I already talked about earlier, which light will not pass through, in a hydrocele, you will get light passing through. So when it comes time to do your differential and you need some clues, that could help you. So let's talk quick about protective equipment. So this was a little bit surprising, but the data to support use of an athletic cup is not awesome. The people who regulate cups, there's no real regulatory body that has a strong ownership over cup. So cups themselves, they're not all that great. They can help with blunt force trauma, but the evidence and the data support using an athletic cup it's not super strong. How about preventative screening? Should we be screening during exams? So the evidence tells us, at least from the USPST task force, that it gets a grade D. So I'm not sure how many people are screening or not, but at least from one of the bodies that we look at for evidence, they actually give it a grade D. At least the last time I checked. It's important to note that if you're not going to screen, at least me personally, I've gone away from it because of the recommendation, but I still counsel patients about if they self-screen. The recommendation I give them is just to be consistent. Don't do it sporadically because they may not know their own body then. And if they see anything or feel anything that looks abnormal, to mention it, bring it up, come and talk to me about it, and then we can address it. Value of ultrasound. I wanted to share this with you guys since I talked about ultrasound quite a bit. But you can see the accuracy. And it's actually a pretty darn good tool when you start talking about testicular injuries, scrotal injuries. You can see some of the sensitivity and specificity numbers. So it's actually not terrible. And finally, this was his late addition today, and it goes back to that cold from the very beginning call out here. So something as recent as this past Winter Olympics in Beijing, cross-country skier suffers frozen penis at start of race because of how cold the temperatures were. So we all heard about how cold it was up on the mountains. So it was cold. Had to pack himself with heat packs at the end of the race. And this is an old reference, but I thought it was interesting. Penile frostbite seen in a runner. Runner was a physician up in New York who suffered frostbite because he went out running in the cold. He was clothed, but it was just too cold. So keep that in mind. And here's some references. Thank you, guys.
That's great. Thanks, Dr. Sandella. Really appreciate it. Let's take a look in the chat. So for everyone that is attending tonight, the the feedback form is in the chat. So if y'all wouldn't mind going in and filling that out, that'd be very helpful. I'll give everyone, a minute or two to put some questions in the chat if you have any. And I actually reached out, I mentioned that professional football player that had the torsion in game, and I reached out to the physician that I knew was on the sidelines for that game and asked how they presented and how they kind of picked it out. And it was the player had just complained of groin pain at halftime, and the athletic trainers just thought, oh, maybe he pulled his groin, but the player had said he didn't have one particular injury. And then over the course of halftime, which is just 15, 20 minutes, his pain got severe. He started having nausea and vomiting. And asking him questions, found out that he had a family history of testicular torsion, and it was either his brother or his father. And so they tried to maneuver in the training room, and it didn't help. So they put him in an ambulance and took him to the hospital. And within a couple hours, he was having surgery for it. There were only a couple games left in the season, and so he missed the rest of the season. I think there were only 2 games left, but the urologist had said kind of 3-4 weeks to return to play after having the surgery. And so when you say in the talk that it's not salvageable after 24 hours, it seems like you said, it'd have to be very remote, because I think the pain is going to be so intense. It's going to be hard to get to the 24-hour mark. He was apparently getting fentanyl for pain is what they were giving him for it. So obviously very severe pain. So that's just a real world example of something that can happen during the course of covering games on the sidelines. So just wanted to provide that. We have one question here. This is from Hamilton. He says, you stated that the data for cups is not very strong. Is that due to lack of research volume in that area, or is the data that is available not convincing? And then secondly, what do you typically tell patients in this regard?
Yeah, thanks. Great question, Hamilton. It's actually the data is not convincing to use them or not use them. There have been a number of studies, and there's just the evidence to use or not use is great. I think it depends on what you're trying to prevent. Not great for preventing testicular torsions, but in ball sports where there are projectiles, I think I recommend, just to prevent from the blunt force trauma and the potential for contusion/rupture. I think it's worth it. Anybody I'm counseling on, if there were a cancer or anything like that, absolutely, just to protect that testicle. I know that, I think, lots of people have thoughts, for or against, some have these superstitions that they think it slows them up or whatever. I don't think that's pertinent in this information. I think you got to look around situation. I've heard enough stories. I was around a baseball team, and there was, there would always be a lot of pushback, and there was pushback until one of the second basemen took a ball. This is at a younger age baseball. This is not professional. So, when you hear that there are, stones on the infield, you'll understand. But baseball took a bounce off of a stone and came up and pretty much cracked the guy's cup in half because it came with that force. So imagine if he wasn't wearing it.
Yeah, I agree with that. Having played baseball through college and playing a lot of infield, I would not have been comfortable with playing without a protective cup. And those, you do hear about those situations where the ball will come up, take a bad hop and come up with such force to break the protective cup. And so I think it's foolish for any infielder, regardless of level of play, not to wear a protective cup just due to the risk of blunt force trauma. And having worn one for many years up through college, it became second nature. You didn't even notice it was there, and it definitely there was no slowing down or anything like that. As someone who relied on me personally, speed as part of my game, that was never a thought that I ever had. So I definitely agree with that. So I have another question here. So similar follow-up question. do those studies regarding cups tease out the type of sports? So contact, non-contact, ball sports?
Yeah, that's a great question. To be honest with you, you know what? I should have reviewed that before giving the talk. I apologize, to see if there's been any update. I don't remember. I'd have to look that up again. From my best recollection, I believe, I think it was all sports, that would be fitting, but I'd have to check to be sure.
I'm just typing something in Google real quick, seeing if I can figure out. Maybe, maybe not. Let's see what the first thing that pops up. Menstrual cups, not what I was looking for. Okay.
Probably not super helpful for testicular injuries.
Right. Not at all. Okay, so give everyone another 30 seconds or so if there are any other questions. Other than that, we'll wrap up. All right, so nothing else popping in. So Dr. Sandella, thanks again for giving this talk. It was excellent. The talk will be put up on the AMSSM YouTube page, probably most likely tomorrow, and for review for murder review purposes or for people's general knowledge. So thanks again, Dr. Sandella. We really appreciate it. And thanks to everyone for tuning in to this edition of the Fellows Online Lecture Series. Thanks.
Thank you.